Welcome to Heart Nurses, brought to you by the Preventive Cardiovascular Nurses Association. PCNA's mission is to promote nurses as leaders in cardiovascular disease prevention and management.
We'd like to welcome our audience today to our conversation with Dr. Valerie Hoover. And could you please introduce yourself to our audience?
Yeah, happy to. So it's great to be here. I'm a cardiac psychologist and was a clinical assistant professor at Stanford in the cardiac behavioral medicine service from 2015 to 2022. I'm on the adjunct faculty now and do cardiac psych work in my private practice.
So we spend a lot of time in the cardiovascular health sphere talking about disease states, talking specifically about treatments, talking about prevention. But we're going to cover a pretty important topic today, and that has to do with mental health issues and cardiovascular disease. If you could start off for us talking a little bit about the prevalence of mental health issues in cardiac populations, please.
Yeah, happy to speak to that. So I guess one thing to know would be that so there's a number of psychiatric mental health disorders that are more prevalent in cardiac patients compared to the general population, including things like depression, various anxiety disorders, post-traumatic stress disorder, panic disorder. So it's really kind of across the board, for the most part, this elevation that we see in the prevalence of mental health issues.
So tell us a little bit more about what that might look like, because I think we, as clinicians, are probably not quite as trained in recognizing the symptomology perhaps that we need to look for and maybe what the next steps should be for our patients.
I'll speak a little bit about depression first. So depression is approximately 2 to 3 times more prevalent among cardiac patients than in the general population. And it's also been found to have an association with adverse cardiac outcomes. So really important one to screen for. Screening is also recommended by the American Heart Association, routine screening for depression. So depression, kind of the cardinal symptoms would be persistently low mood and loss of interest in things that someone used to enjoy. So a hard time kind of deriving pleasure or joy from their daily activities. And these, we kind of have normal fluctuations in mood. It's we all probably have some experience of that at some point. The difference with depression is that people are down and they stay feeling down for at least a couple of weeks. More likely it's months, like 6 to 9 months. There's some other symptoms that kind of go along with depression as well. We can think of some of these as more kind of mood related or cognitive, and then others as kind of more physical or somatic. So some of the somatic symptoms would be things like changes in appetite in either direction. So, having more or less of a desire to eat, possibly even weight changes. Differences in sleep, either wanting to sleep a lot more or having trouble sleeping, trouble concentrating. And then folks will also often kind of have changes in how they feel about themselves, or a sense of almost like kind of disconnection from other people and a tendency to self-isolate. And of course, with depression, it's not uncommon, especially kind of more moderate to severe depression, it's not uncommon for folks to have thoughts of, anything from, gee, it would be easier if I just didn't wake up in the morning, all the way up to, I don't want to live and I have a plan and I intend to follow through on that plan, and a lot in between. And so just kind of, I think it's helpful to kind of be aware of how common those types of thoughts are. It doesn't mean that patients are going to make an attempt to end their life. It's more kind of representative, I think, of how hopeless they can feel. And certainly if there is suicidal ideation, we want to address that. But also it can just kind of be a reflection of some of that hopelessness.
So when a patient gets a diagnosis of heart failure, for example, the word fail is right in the name of that disease. I understand where that might be a pretty obvious patient that we might want to screen for, but from what I'm hearing, it sounds like it's much more pervasive than just in our most severely impacted patients.
Yeah, great point. So So absolutely, it's a big issue among, highly prevalent among folks with heart failure, but also prevalent in folks with other kinds of cardiovascular disorders as well. And so we really need to kind of be thinking more broadly about screening folks with cardiovascular disease for co-occurring mental health issues.
And you also had mentioned about screening tools. Could you talk a little bit about if these are traditional screening tools that would be used in other situations, or if there's some cardiac-specific tools that we would use?
Yeah, I'm happy to speak to that. So traditionally, and actually there was thinking of a paper it was a white paper that the AHA put out, I want to say in 2009, recommending initial screening with what's called the Patient Health Questionnaire 2 or the PHQ-2, and following that up with what's called the PHQ-9, just a more in-depth screener for depression, and doing that with all cardiac patients. And Jack published a review in 2019 kind of saying the same thing, right? So those are if you're thinking about doing some sort of depression screening in your setting, starting with a PHQ-2, it asks about those 2 cardinal symptoms of depression that I mentioned earlier in the past 2 weeks. A score of 3 or more would indicate a positive screen, and then you would want to follow that up with a more in-depth assessment with like the PHQ-9. And again, if I can get the resource for that Jack article, there's a detailed kind of explanation of how to kind of move through that screening process, but it's probably beyond the scope of what we can cover here today.
We'll be sure to put that link to that resource in the show notes for our listeners.
And then one other thing I'll just mention when thinking about screening, and I think the second part of your question was something about like, is there a cardiac specific measure? And there in the past, the answer would have been there's a bunch and they're all piecemeal and they all kind of look at one piece of it. But recently, actually, my colleagues at the Australian Centre for Heart Health in Melbourne, Australia, developed, and we were one of the sites at Stanford that tested it along with some other sites, a comprehensive measure of cardiac distress in this population. It assesses 8 different areas of psychosocial functioning, and it's freely available. So you can just go to the Australian Centre for Heart Health, their website, click on resources, and you'll see it's called, again, Cardiac Distress Inventory, or CDI, free to download and use. And I believe you can access the article reporting kind of the study results and how it was tested. I'll mention, so this is kind of a lengthy measure. It's 55 items. So there's now also, it'll be released shortly, a 12-item measure that's going to be a lot more feasible for a lot of professionals in various settings than a 55-item measure, I think. We're waiting on the results to be published, but once they're published, that'll also be up there on that website and freely available.
So in terms of what this looks like in clinical practice, I suspect that a clinician might have a patient where there are indications that there might need to be this next step. Do those resources get utilized in that same clinical visit so that you can have immediate results?
Great question. So if I'm just understanding correctly, let's say a provider's, working with a patient, or a nurse is working with a patient, and they have a sense, this patient, I'm sensing some depression here. Let's screen for this.
Yes.
Absolutely. Yeah. And it's, if there's already a screening process in place, maybe they filled out that screener ahead of time, and you can just kind of initiate that conversation with them about, mood and depression and possible treatment from that screener. If it's not already, part of the screening procedure in the setting where you're in, absolutely. You could get out the screener and kind of go through it with them. I find it's helpful to kind of normalize it. I think, unfortunately, it's getting better, but I think there still is this stigma around mental health. So just kind of saying something like, we often, or always, if it's with every patient, but we often like to screen our patients for depression. We know it's 2 or 3 times more common if you have a cardiac condition, and it actually, folks tend to not do as well medically if it doesn't get treated. So would it be all right if we take a couple minutes to do a quick screener?
And also for the clinicians to be thinking about next steps, about what those results look like. So in your clinical setting, obviously, you may be receiving referrals from clinicians. Is that how that works?
Exactly. Yeah. So in kind of how I function as a cardiac psychologist, so I'll get a referral from a member of the treatment team. Cardiac psychology is a bit of a newer field, so there's not many of people doing what I do. But if you don't have a cardiac psychologist, some other options would be if there's someone on the medical team. So let's say that the patient screens positive. It's clear they have depression. The current recommendation would be to initiate medication like an SSRI. And so if there's, a member of the medical team who can prescribe that and is comfortable doing that, that would be one option. You could also loop in the primary care provider. If the patient is hospitalized, you can get a psychiatry consult or refer out as well. For patients who would prefer not to do medication or who have tried medication and failed an initial trial, a referral for therapy is also a great option.
We've been talking about the connection of mental health and cardiovascular disease, and we will be right back.
For more education, resources, and tools for your clinical practice, visit pcna.net. You'll find CE courses, patient handouts, and more, all free to access. Visit pcna.net.
And we're back talking about cardiovascular disease and the links to mental health. I'm hoping, Valerie, you could talk a little bit about how cardiovascular outcomes are impacted by mental health.
Absolutely. What immediately comes to mind, so there was a white paper put out by the AHA. It was a couple years ago, I think in 2021, looking at and reviewing the current state of the literature on positive and negative psychological factors and various cardiac outcomes. And what they found is that a number of psychological factors, in addition to depression, are associated with things like greater incidence of incident CHD, MI, mortality, and just to give you a flavor, some of those other factors that show an increased risk are things like PTSD. Social isolation, loneliness, stress, both specifically work stress and any cause stress, anxiety, if I'm remembering correctly. One of the findings that really kind of struck me is a 420% increased risk for coronary artery spasm for folks with high levels of anxiety. So really kind of striking effect. They also found an association of pessimism. So kind of this overall tendency to predict negative outcomes or ascribe a negative interpretation to kind of more ambiguous events. That was also associated with greater odds of CHD mortality. On the flip side of that, and this is a relatively newer area of research, but I mentioned they also looked at positive psychological factors and cardiac outcomes. And positive psychological factors, so this is more than just the absence of things like depression or PTSD or anxiety. It's the presence of things like optimism, like having a sense of purpose, greater sense like mindfulness, having a more kind of positive affect or reporting higher levels of happiness. All of this has been associated with actually reduced risk for some of those same outcomes. And the good news there, one of the things that I find really heartening, so to speak, is that a lot of those are qualities and kind of states of mind and stances that can be cultivated and developed. So I find a lot of hopefulness in that, and I'm hoping there's a lot more to come on that topic in the next number of years.
It's incredibly insightful that we can have a positive impact with some of these outcomes for our patients as well. And as you were speaking about those connections between mental health and cardiovascular disease, both in both directions, that they impact one another. It came to mind that those individuals who are not just patients, but families, caregivers, those types of individuals are also at greater risk than for cardiovascular disease if they perhaps have somebody who's been recently diagnosed or is going through a chronic condition. So in some ways, this is a family affair in terms of making sure that patients and their close friends, their families, have access to resources and information. Is that accurate?
That is such a great point. So, like you said, right? So in addition to the patient, there's kind of these outward ripple effects. So family member, both kind of directly, they're, especially depending on the condition, there may be like an increased risk for that same issue in family members, and in addition to that, kind of the stress and the difficulty that having, a family member who's maybe gone through some kind of gotten a new diagnosis or had some kind of cardiac event, just kind of the fear and kind of how that disrupts kind of that family unit or that social unit. And then, there can be this thing, it really depends on, it's obviously a little bit different with everyone, but something I've seen a lot in my work is kind of this dynamic that can unfold where, the patient is, they just had this thing happen or gotten this diagnosis and they're concerned about either being a burden or becoming a burden. And that might make them a lot more reluctant to ask for, emotional support or kind of instrumental help with something. In turn, family members, they generally, they want to help, right? And so it can just set up a difficult dynamic when the patient, has this sense of or fear of becoming a burden, so maybe isn't kind of as open to accepting help the family member wants to help, maybe doesn't know how to. It can just be difficult. So I think something I try and, remind my patients of is, when we allow others to step in and help us, not only does that benefit us, but it benefits the other person. And, all we have to do is kind of think about a time where kind of we've been in that position, right? So maybe a friend or a family member asked us for help or confided in us or opened up to us, and kind of really reflecting on kind of how that made you feel and how that benefited the relationship, perhaps. And so, what's good for the goose is good for the gander. So maybe being more open that to accepting that help as well if you're in the patient role.
So we've been having a fascinating conversation about the links between mental health and cardiovascular disease. Is there anything else that you would like to add that we've neglected to talk about already?
I think those are the big things. I will just say, I guess to kind of attempt to sum it up, we know that a number of many different psychiatric disorders are more common among cardiac patients, including depression, anxiety, PTSD. And so just, to kind of be aware of that and working with patients, and, perhaps having screening procedures in place to help identify them, or if they're not in place, like you, I think, may have mentioned earlier, if you're picking up on it during an interaction, taking that moment to kind of dig a little deeper and then kind of doing what you can. Ultimately, it's the patient who will decide if they're going to accept and pursue help and treatment. But kind of having that conversation and, doing what you can to kind of help get them connected.
I really appreciate your insights into this added dimension of healthcare for our patients who often have very complex health issues already, to be aware of their mental health and how we can help them in all those spheres and have the resources there. Thank you so very much for being with us today. I'm your host, Geraldine Warfield, and we will see you next time.
Thank you for listening to Heart Nurses. We invite you to visit pcna.net for clinical resources, continuing education, and much more.